Welcome to Focus Today. I'm your host, Perry Atkinson. Always a delight to have Dr. Klein with us today. He's here from Ventana Wellness. And by the way, if you want to join the conversation, he's with us for a couple of segments. You're welcome to do that. The phone number is 541-776-5368. Ask the doc. 541-776-5368 or toll free 1-800-373-5368. We're going to talk about cancer screening today, and this is really something. So what is it? What are all the various types?
So usually I'm, as always, I'm the fly in the ointment, wanting people to think about, there are more controversies around cancer screening. So typically we're thinking about, what I want to really more talk about are the controversies in it. But, for breast, colon, prostate, cervical cancer, so it's pap smears, it's colonoscopies, it's PSA testing, mammograms, and those kind of things, and how much good they really do, depending on who you talk to. The main thing is the model that's been used over the past 150 years is that, okay, cancer, if it develops, will need to grow to a certain size before it breaks out into either the bloodstream or the lymphatic system. And if we can catch it before it breaks out, that's obviously the prevention of the disease that kills people. People don't die of the actual tumor, they die of it spreading through the body. So the whole point was, can we catch it? And this was thought to be pretty universal. It turns out that for some tumors, it does not work as well that way. Colon cancer seems to be one that we still, the risks don't outweigh the benefits that we get from that. Cervical cancer pap smears are universally hailed. They make a difference. But more and more recently, both prostate and breast cancer screening have come under question, particularly by what's an independent board of preventive medicine specialists called the United States Preventative Services Task Force. And people may not know about this group, but this is the group that is assigned with making recommendations on all the things that can be construed as preventative services, preventative medicine, based on strictly the studies, the data that we have right now of what do the studies show. They're really doing this evidence-based. Are we really making a difference? And that's where things start to become more controversial.
Wow. So what you're thinking on that, I mean, are we making a difference with this stuff?
Depends on which cancer.
Okay.
So this is the problem. And I know it unfortunately, like one patient a long time ago, this was, 15, 16 years ago, I was having this conversation with a patient about the questions about prostate cancer. And he thought, well, I just thought you get this test, it tells you if you have cancer and you get it treated and that's it. It says, right. Well, it turns out it's not quite that easy. With prostate and breast cancer, we're dealing with situations, and most cancers, but the behavior of the tumor will depend on which genetic mutations the tumor has. And this is more research that's been over the past few decades. Tumors with certain mutations will never cause the person a problem to begin with. They were not going to die from that tumor. So treating those tumors may very well be unnecessary, even though nobody feels comfortable doing nothing about cancer, because there's, of course, this general fear about it that what the data is showing may or may not be justified. Tumors with the bad acting mutations, by the time we even find them on the current screening exams, may have already broken out. So you have a question of, are we really doing people good? And when they really look at the data, it's questionable. In fact, we can start with the PSA, because this has been very controversial. Right. The prostate-specific antigen testing. The committee currently came out with a recommendation completely against doing it altogether.
The PSA test? Not
doing a PSA. They felt that, number one, at best, we're saving one life for every 1,000 tests done. But for that, every one life saved, you're going to have 30 to 40 men who are permanently impotent and incontinent from the treatment of the prostate cancer, 2 who will die of a heart attack from treatment of the prostate cancer, and 1 who will die of a blood clot. So for every life saved, you're either losing or certainly decreasing the quality significantly of 40-some lives. And their opinion at this time is that that's not a reasonable benefit. Now we can argue, because then they're dispassionately looking at the data. Right. But I want people to know that this is just not as cut and dried as sometimes it has been presented, certainly in the media at times.
Let me just say to our viewers and listeners, you want to join us, 541-776-5368 or toll free 1-800-373-5368. We're talking about the various cancer screening tests and things. You know, back to the PSA just for a moment. PSA can go up and down, right?
Can.
Because I've heard of gentlemen who got the PSA test, overreacted, and went through all this treatment, and it turned out it wasn't necessary.
Right.
You know, and I'm going...
Well, this is the whole thing about screening tests. What they look at is how sensitive is the test, meaning of people that have the tumor, what percentage of them is it going to be picked up? But even probably more importantly in this case is what's called specificity. How specific is the test? So for people who don't have a tumor, what percentage of the tests are going to be negative? And that's where you get into more problems. PSA can go up from a prostate infection, from low-grade inflammation, just from benign enlargement of the prostate. And there's this huge overlap area. So it's felt that a PSA below 4 is normal. A PSA above 10 has a much higher risk of cancer. You have this whole gray area between 4 and 10 where it's not really clear. So this is where a lot of people are being tested, and they get ultrasounds and biopsies. And the biopsy involves 12 needles into the prostate, to 12 different quadrants to do that, of which there is risk of infection and bleeding and those kind of things. To do that, and you're having a lot of people in that middle range who are being tested because it's not clear.
Wow. So what other tests would you use for prostate cancer?
We don't have one. As always.
So it's the only one available right now.
That's what we got. So true prevention of cancer, not early detection, which is actually what in epidemiology would be called secondary prevention, is how do you keep it from getting worse. Primary prevention, actually preventing the tumor, comes down to our old friends, diet, lifestyle. Certainly men who have the diabetes, pre-diabetic, have the big gut, that fat tissue in the beer belly promotes inflammation and produces more estrogen. And that seems to be a risk factor in the development of prostate cancer. So again, it's the anti-cancer diet of lots of healthy, fresh produce, keeping closer to ideal body weight, exercise, all the same health things we hear about for everything else. That's how to prevent prostate cancer.
I've heard it said, men, you're going to get it, it's just a matter of time.
Well, that's true, and that's the other issue. So there's no screening currently recommended for men over 70. Because if a prostate cancer that occurs after the age of 70 is much more likely to be one that you will die with rather than from. They won't have the bad mutations that cause it to spread. So yes, if you take men who've reached the age of 90 and you do autopsies when they die, 90-some% of them will have some degree of prostate cells in their cancer. But it's meaningless. If they grow in there, they don't spread, it's not a problem.
All right, breast cancer, it just seems to be almost epidemic.
Well, this is the problem. 1 in 8 women will get breast cancer. And yet, everything that we're doing, it seems, again, what the task force looks at is that mammograms seem to do the best job between ages 60 and 70, women in their 60s. Women in their 40s, there's a high degree of false positives because they are still in reproductive years. The hormone changes that happen with women who are still menstruating will cause the breast tissue to be more difficult to see tumors when they're in there. The tumor is denser. So you get a lot of false positives with a lot of biopsies, and the like. Even between women between 50 and 59, mammograms seem to be a little bit better, but in terms of what they would talk about, what the task force looks at is how many tests do we need to do to save one life? And for women in their 40s, we have to do 1,900 mammograms to save one life. And with women in their 50s, for various reasons, it goes down to 1,300. They make kind of an arbitrary decision to say, well, we don't think it's worthwhile in the 40s, but it seems like we should be doing in the 50s. But even then, at least the studies show that doing them every other year is no worse than doing them every year. So whether women even need a yearly mammogram. There were some newer technologies out there with digital mammograms, with MRIs that are getting more expensive, do seem to detect things better, but they don't feel that there's sufficient evidence right now to say, yes, we really should be doing these.
All right, let me take a break. We'll come back. I want to ask you a couple things. There seems to be, you can do some screening and everything may be normal, but cancer may be there.
Right. That would be called false negatives on the screening exam.
Okay,
right.
And then the other thing is cancer overall just seems to be epidemic.
Well, sure.
And I mean, it's just unbelievable. So anyway, Dr. Joel Klein's with us from Ventana Wellness. If you want to join us, the phone number is 541-776-5368 or toll free if you're outside the immediate Medford area, 1-800-373-5368. We'll be right back. Okay, we're back with Dr. Joel Klein, and he's a physician with Ventana Wellness, and we're talking about the C word, cancer, and cancer screening and types. And as we were going to the break, Dr. Klein, I asked you the question. It just seems that cancer is epidemic. I mean, where was it 100 years ago compared to where it is today?
I can tell you. Actually, people have looked at this, particularly in Victorian era England. This is fascinating. I was listening to a gentleman who studied this, who everyone said, oh, he must be misinformed, till a historian came by and said, no, he's right. And let's say in Victoria era England, late 1800s, the truth is, number one, if you lived past the age of 5, there was a high degree of infant mortality. They lived as long or longer than we do now. It is a myth that we live longer than anybody else has. There was high infant mortality, so overall, people lived not as long if you did a statistical analysis. But once you live past the age of 5, they lived as long or longer. This was the heyday of anatomical pathology, when doctors were doing several autopsies a week on people, 2 to 3 a week, and cancer was uncommon. 10% maybe, and they guessed that that was probably the certain amount of genetic cancers that we all hear about, the gene components, maybe comprise 5 to 10% of total cancers. And that's what they were seeing. 10% of patients died from cancer 150 years ago. And less environmental toxins and more produce in the diet.
Okay, so the flip side of that is that's what you think the rise of cancer is all about?
It seems to be. Certainly our pro-inflammatory diets, and certainly to whatever degree the amount of environmental toxins we're being exposed to, 500 new chemicals being introduced into the environment every year is a number that I have heard. And of course, the problem is you have to prove the chemical is dangerous to have it removed. It's the flip side of drugs, where you have to prove they're safe. And it's very hard. That's why these people have very tough legal cases to prove that it was that chemical that caused that problem, because we live in this soup. So how do you prove it was that company's one chemical that caused the problem? Can be very difficult.
Is it true? You're the doctor, so I'm just going by rumors, I guess, or thoughts. Is it true that the younger you are, the higher risk for, if you get cancer, the mortality rate's higher if you're younger versus if you're older?
It does seem to hold that way. I don't know the actual statistics, but it seems, again, since cancer is kind of a degenerative disease as well that goes along with aging. Now, we're not talking about the childhood lymphomas and leukemia as a completely different category. But the regular cancers, it seems as though if whatever conditions that led to the development of that cancer, if they were that severe that somebody in their 30s and 40s gets cancer, it's usually much more common for that to be a really bad actor and one that will spread more quickly.
How many types of cancer are there?
Every tissue in the body can develop a cancer, theoretically.
Okay.
So that's the thing. Cancer is not one thing, it's hundreds. You know, overgrowth of cells from any type of tissue. Obviously, we look at all the different organs, connective tissue, nervous system. So there's a huge, variety, and they don't all behave the same way. And that's why to just talk about cancer as a single entity really may not be helpful.
All right, let's go to the phone. Hi, Angie. You're on the you're with Dr. Klein.
Good morning. Hi, Perry
morning.
and Dr. Klein.
Hi.
Hi there. I have a question. I'm wondering what your opinion is of thermography as a tool to detect breast cancer and other cancers.
But the thing about thermography is it's a better functional test. It just has not been studied as well, so we don't have the data on it. My personal experience and with patients is that I think it can be very helpful. And I worked with a thermographer back in Colorado who had gotten so good with her technique and all that, that she was able to convince one of the breast surgeons in town to be able to do a biopsy solely on the thermography and an ultrasound test without having to do the radiation from mammogram, because they felt it was that dependable. It supposedly catches things way before they cause a problem because of blood flow changes and all that. So while we don't have the data on, how good is this in terms of prevention? Is it going to be better than mammograms? Because the people who are going to pay for that huge of a study are not going to look at thermography. I tend to be in favor of it when used with other modalities and really as part of the whole picture.
Mm-hmm. Okay, very good. Thank you.
Thank you, Angie. Colon cancer. And of course, the obvious screening for that, is it effective? Does it work?
Yes. I mean, this is the thing. It's felt, the problem is colon cancer does not fit the model that prostate and breast do. It really does seem like we know how the cancers develop. They develop in these polyps. They take years to grow to a certain size. The treatment of them is relatively benign. If you can catch that polyp on a colonoscopy rather than an invasive surgery, seems to be curative. So the problem is there are some complications with colonoscopy, though they are few, and they are expensive, and we don't have enough gastroenterologists in the country to do colonoscopies on everybody who should. Yeah. So they're still recommending like the fecal blood test, which has a high rate of false positives. You can have blood in your stool from almost anything. Taking a few aspirin, too much vitamin C, other things that are going on, that hemorrhoids, obviously, or even an ulcer will cause the blood on the stool test. And the sigmoidoscopy, whereas maybe 30 years ago was really good, it turns out, and maybe because we're exposed to higher concentration of toxins, I was taught in medical school that 25% of colon cancer was in reach of the doctor's finger. They were all down there at the bottom, a quarter of them. Mm-hmm. Does not hold true anymore. They're moving more and more over to the right side of the colon, where they can only be seen with colonoscopy. So that's one I do tend to favor, because it does seem we can get it early enough without too much trauma and complications for the patient.
Well, some insurance companies say it's preventative.
Oh yeah, and that's the thing. Yeah. The whole thing for the insurance companies is it cost effective? Yeah. I think it's definitely beneficial, but from their standpoint, are they saving enough money in treating colon cancer patients by getting them early with what you're spending on the colonoscopies?
How often do you recommend?
The recommendation is at age 50. Everyone should get testing. And if it's colonoscopy, you can actually get one every 10 years after that, and really only up till age 70, 75. After 75, no one recommends doing it. If you have polyps, have those types of things found on the colonoscopy, then that needs to be followed up sooner. The other change for that, if you have a first-degree relative, a sibling or a parent who had diagnosed with colon cancer before the age of 60, then you should have it 10 years before the age they were when they were diagnosed. So let's say they were diagnosed at 57, you should have a colonoscopy at 47, not at 50.
Okay. All right, the common treatments is radiation and chemotherapy. Your thoughts on that?
That would be a whole nother show that we could talk about. I think there are people doing some very good work in this area that is just being studied. Even the big experts at the major cancer centers will tell you that still trials that are being done now are not being done with this knowledge that we've had over that. Again, not only do tumors with certain mutations behave in a certain way, they also respond better to certain drugs. That knowledge is not being used. It turns out it matters less whether it's a colon or a breast or a stomach cancer, as opposed to what's the genetic mutation driving the tumor, and there's testing that can be done for that, and they just haven't studied that on a large level.
Well, on that subject, Dr. Klein, I've been reading as they begin to study the mutation of the various cells, that they can pinpoint a chemo drug that will attack just that.
That's what I'm saying. Yeah. Exactly. Now, the drug companies will develop certain drugs along those lines. They're doing more of these monoclonal antibodies like Herceptin, but it turns out even the regular chemotherapy drugs, not these newer antibody-directed biological agent drugs, you can determine from there which tumors may respond better.
Do you see the industry going there?
Yes, but at a glacial pace.
Okay.
unfortunately.
Why? Yeah, because it seems to be effective. Okay, bureaucracy. We'll
bureaucracy and money, yes.
Okay.
Yes.
Hi, Bob. You're on the air with Dr. Klein. Go ahead.
Thank you, Perry. Thank you, Dr. Klein. I was wondering if you could make any kind of a comment regarding, you mentioned in general exposure to toxins in the environment. I'm looking at it from a direction of mega farming, monocropping, utilizing a lot of petroleum-based fertilizers, and then picking the food green so that essentially it looks good when it's on the shelf later.
That's part of it, certainly. And then all the industrial chemicals, everything else that's being used. Yes, that's part of this huge load that we've taken, and with industrial farming, commercial farming over the past 50 to 75 years, plus the practice of not allowing fields to go fallow and rotating crops like we've been told from the beginning of time, because the soil needs to recover. So the plants that we have that are supposed to have certain nutrients don't have them anymore because the soil's been depleted. Any and all of it, this is the problem. All of these things together are likely playing a role in how we separate them out, so that because the industry will claim, well, you can't prove this, you can't prove that, because it's all of them are happening at the same time. But instinctively, we know that all of these things are likely causing a problem.
Right. Thank you.
Thank you,
Sure.
Bob. Interesting. Those who have gone through chemo and their immune system is pretty much knocked down at the end, is there something they can do to build that back up? Is there a natural system or course they can do?
Biggest thing after chemotherapy, in my experience, of course, is all the damage to the gastrointestinal tract. And so if we are going to heal from all that, we need to be able to properly digest and assimilate our food.
Right. And
there's no healing, because all the healing of the GI tract that will be done is done with naturopathic means to bring back, replacing, well, of course, they're starting to realize that bacteria in our gut are important. Probiotics. There are all kinds of herbs and supplements that are made for these healing things of the gut to do that, so we can actually properly digest and assimilate our foods. There are a lot of other naturopathic things that can be done for that, and the people that I know who are doing good work are working with really good herbal things for the immune system and all of that. So there's a lot that can be done.
Can they be done simultaneously with chemo?
That is a big controversial question, because the oncologists are concerned that the herbs will interfere with the chemo, when all the data that they have, and now a lot of this is test tube data, shows that the herbs actually help block mechanisms that the tumors use to become resistant to the chemo. So they actually help the chemo if you use them the right way. And the thing about vitamins in chemotherapy, and there's some people who've written some very detailed articles on this, there's almost every study that's been done, with few exceptions, either shows no interference at all or a positive effect from using nutrients with the chemotherapy. The oncologists are still very nervous about, anything that could possibly interfere with the chemo, so they're usually not going to be in favor of that.
All right, let me squeeze in one more question. Hi, Chris, you're on the air with Dr. Klein. Go ahead.
Hello, I just have a question. A friend of mine gave me an article on vitamins that, like multivitamins, vitamin E, C, that there's all this testing that they don't do any good at all. And so I'm just kind of wanted to get your opinion on what you thought about that.
I don't know what you're talking about, so you need to be more specific about what kind of the studies? Yeah, the problem is they do isolated studies. I get it. On vitamin E or vitamin C, and these are isolated types of things, but at least that they do no harm. The problem is they're typically using forms of vitamin E that have never existed in nature, which is the stuff that you can buy very cheap at Costco or Walmart, and vitamin C issues. So the studies are a lot of times being done in ways that aren't likely to show a benefit anyway. So it all depends on how you interpret the studies. There are other studies that will show potential benefit. I don't think just taking them willy-nilly is a good strategy. There are people who are smart doing this, applying this in very specific ways that make a lot of sense. But if you're just going to take a whole bunch of vitamins, that probably is not going to be very helpful.
But just like a general multi and some extra C and
that won't help. That won't hurt anybody. But the question is, how much good will it do? I think that's a question, but it certainly can't hurt. I think. But again, we're looking at mega doses of things that the whole question, and this is detailed, I have to go into it, that most chemotherapy does not work by an oxidative mechanism, so taking antioxidants actually will not affect it. And that's a whole nother long discussion we could do a whole nother program on.
This is fascinating, Dr. Klein. I think you touched a real nerve here because cancer is so much a part of our lives today, and everybody's asking these basic questions about it. And so thanks for your time. Can't wait to get you back in.
All right, I'll be back in a month and we can pick it up then.
There we go. And Dr. Klein, he's a physician with Ventana Wellness, and if you're looking for a good doc, there's one right there. Thanks for coming in.
Barry.
All right, we'll be right back.